All right, hi, welcome everybody. We are going to go ahead and get started since it is 5:30. Thank you so much for joining us for our COVID-19 speaker series tonight. My name is Corey Slack. I'm the Associate Director of Alumni Engagement. And while I am talking, please feel free to just take a quick moment and download our alumni app. It is a free app. It will update you on events, anything that's going on with CSU, things that the Alumni Association is doing. Hopefully once we get back into playing football, we'll have some football things getting updated there too. And like I said, it's a free app. We're not gonna ask you for money to download something that's just informational for you. We understand that these are challenging times for many different reasons, but we are so happy that you are here to join us tonight. And we hope that this is a fun and educational webinar for you all. We are here to build RAM pride and RAM community, and we hope that this is just one of the many ways that we could do that. This is our 9th presentation of the COVID-19 series, so we are so excited that it's going strong and people are enjoying it. If you ever have any questions or ideas of what we could do as far as the series goes, please feel free to fill out the survey that you're going to get in a couple of days after this event. I would like to thank everybody that's here tonight for taking the time out of your day, but we specifically want to thank all of our members that are here tonight. Without you, we would not be able to do events like this. We would not be able to do any events in person before COVID hit. So we are so thankful for our members that are here tonight. If you're ever interested in hearing what membership is about, I will put in a link in the chat that will direct you over to our membership webpage and connect you with all of our information. Speaking of the chat, while I am talking, if you would like to introduce yourself, please feel free to change your chat feature from the two. It says 2 attendees right now. If you want to change it to attendees and panelists, you can talk to everybody. You can introduce yourself, say your name, what year you graduated, and where you're streaming from tonight. Typically, we get people from all over the country, all over the world in some cases. So feel free to introduce yourselves. I would also like to take a moment to thank all of our sponsors that have helped put this series together. We have Women in Philanthropy. We also have the Vice President for Research. And then we also have the College of Veterinary Medicine and Biomedical Sciences. Without them, we would not be able to find our speakers. We would not be able to have people like Ray here to do these awesome presentations that people have been loving to do. Just as a reminder as well, this presentation tonight is a webinar, so we cannot see you or hear you, but feel free to ask questions in the chat feature, ask questions in the Q&A feature. I will be monitoring them and then sending them over to Ray throughout the presentation so that we can answer them at the very end. But do not hesitate to write any questions down. If you don't understand something, we'd be happy to try to explain it a little bit more too. In just a few moments, I'm also going to add some technology issues or anything that's going to go. If you get a technology issue, I will put my contact information in the chat. I will also have some links so that you can help fix something if you can't hear or see something on the screen. Feel free to shoot me an email, shoot me a text. I will be monitoring my phone and my email throughout the presentation. And now I'm super excited to introduce you tonight's guest speaker. We have Dr. Ray Goodrich. Ray has worked in the medical field the medical research field for over 29 years, during which he's managed research staff and development programs in the fields of transfusion and transplantation medicine and pathogen reduction technologies. Ray has been awarded over 50 patents covering technology in these areas and has co-authored over 200 peer-reviewed articles and abstracts as well. Ray has also served as the principal investigator for grants totaling over $40 million from the United States Department of Defense for the development of transportable blood treatment system. We are so thrilled to have Ray here tonight. And Ray, without further ado, I'm going to go ahead and let you take it from here.
Thank you, Corey. Let me share my screen here. Sure everyone can see that.
Yep,
Is that
you're good
visible
to
to
go.
you? Okay, excellent. It's my pleasure to be here this evening. Thank you for coming. I'm sure there are some better things to do at least 5:30 on a Thursday night. For most people, I'll try to make it worth your while. As Corey described, it's my great pleasure to serve as the executive director of the Infectious Disease Research Center, Colorado State University, and also as a professor in the Department of Microbiology, Immunology, and Pathology here at CSU, a position that I've been in since 2016. I have a few conflict of interest statements that I want to make up front. Just a little bit of my background. As you heard, I am an inventor of pathogen reduction technology, or PRT methods, that are used for blood products, as Corey described. I've also served as a consultant to organizations that are developing pathogen reduction and diagnostic testing methods for blood products. My views do not necessarily reflect those of Colorado State University, and my views do not necessarily reflect those of the U.S. Department of Defense, the Department of Health and Human Services, or other government agencies that I am currently or have been affiliated with, just to make those disclosures up front. I have spent a great deal of my career, over 30 years now, working in the field of transfusion medicine. And one of the reasons and the ways to prevent transfusion transmitted diseases. And one of the reasons for that was an early recognition that how important blood is in medical procedures and medical practices around the world. It, as depicted here, it's something that's used in elderly patients, something that's used in very young patients, something that has utility in permitting surgeries or surgical interventions to occur. So spanning the complete span from the very young to the very old, to the very critical, to the chronic cases of transfusion support of individuals with certain blood disorders. The importance of blood in community health can't be overemphasized. I remember many years ago having a conversation with John Mahama, who was president of Ghana, during a World Sickle Cell Disease Day sponsored by the World Health Organization. And I equated a safe and available blood supply as almost the equivalent of a safe and available water supply for community health. It's something that's essential in providing medical care. If you haven't considered giving blood and you're eligible to do so, I would highly recommend it. It is something that does save lives and impacts lives in a very positive way. And I will start off by saying that the blood supply is safer than it ever has been in history because of the interventions of new technologies and new approaches, new standards and practices that groups like the FDA, ABB, ISBT, and World Health Organization have put in place. Nothing that I'm going to say during this presentation will change that or alter that. That is true, but it will tell a story relative to where we've been, where we are, and where we're heading in some regards with regard to issues related to blood safety. So again, I mentioned that this is such a life-saving and life-giving product, which it is. And importantly, it's also one that faces challenges relative to the safety of those products being transfused. There can be contaminants that are present in those blood products that result from the fact that these are taken from human donors, and human donors are susceptible to disease, whether they're viral, parasitic, or bacterial infections. They have these agents have the capacity to be present in blood, to be transmitted by blood, and to cause infection in the recipients of those blood products. There can also be contamination that's introduced during the collection and processing of blood products, either through non-sterile techniques or the fact that you are drawing from a donation site where skin plugs and other contaminants can enter into the blood supply. And what that results in is unsafe blood. where you can have infections that are transmitted from the donor to the recipient inadvertently, of course, and unfortunately, in many cases, with severe consequences. There's been a history of this in the blood community, and I'm pointing out one particular issue that occurred during the period of HIV's entrance into the blood supply during the late 70s, early to mid 80s, which caused a considerable concern and impact on the blood community. And I call out in particular this Creever inquiry. This is Justice Horace Creever. His picture is here in the lower left corner. And he was a member of the Canadian Supreme Court system, High Court system, and led an inquiry that occurred in Canada due to the infection of, as stipulated here, thousands of Canadians with the AIDS virus and hepatitis C. And it was one of the worst ever preventable public health disasters that occurred in Canada in the last couple of decades. It resulted in and again, I'm pointing this out not because to say that Canada is the only place where this occurred. There were many places in the world at that time where this was occurring, and primarily driven by the fact that we had a new virus that emerged into human populations for which we didn't have a lot of data or a lot of information. And blood products still needed to be used. They still needed to be transfused. There's really no adequate substitute for them. And as a result of using those products, it led to infections in many individuals, and people died from it. Families were impacted by it. And it led to a lot of soul searching that went on. And really, I compliment the Canadians for the work that they did to identify what the problems were and to take actions to correct them. And some of the actions that occurred here, for example, was the creation of Canadian Blood Services and Hemo Quebec, located in Montreal. And in order to address issues of blood safety, blood processing, create more consistent policy making. And it's really one of those organizations today that's pointed to as an example of a great success of learning from tragedy, learning from mistakes, and creating systems that work much better and much more effectively in protecting patients who rely on these blood products. The story didn't stop with HIV. In many ways, it raised awareness to a new level that made us aware of the potential threats or concerns that may occur due to the introduction of new agents into human populations, and hence, by virtue of that introduction into the blood donors who are providing these products that are used to support patients in need. This is an editorial that I wrote a few years ago, back in 2018, that talked about some history of this and why we need to remain vigilant relative to the emergence of these new diseases. And as I indicated here in this article, if you look at the history, particularly the period from like 1940 to 2004 and some studies that were done, about 5.3 viruses emerged per year during that period, of which 60 to 70% were human pathogens. Now, not all of them resulted in transfusion transmissible diseases. Not all of them emerged and remained or became endemic in populations, but just the fact that this kind of frequency is occurring indicates that eventually we may be facing another situation where an agent emerges that does have an impact in human populations, does have transfusion transmission occurring, and could be a recapitulation, if we're not careful, of some of the concerns and some of the things that we saw with the emergence of HIV into human populations in the 70s and 80s and into the 90s. And so this editorial was really written to discuss some of this and to say, we need to continue to surveil populations and to understand the dynamics of these diseases and the impact that they may have, not only in just general human disease, but also their potential impact to the blood supply. And then along comes the story of coronaviruses, and we all have the experience of what we've gone through this past year as the understanding of the impact that an emerging disease into human populations can have. Just a little bit of background on coronaviruses. The corona name comes from the morphology that you see under electron microscopy, where you have a crown or an outer shell of the virus that's surrounded by a crown of these spike proteins. And you can see in the depiction off to the right what under an electron microscope these components look like. Coronaviruses and human coronaviruses were first discovered in around 1965. All human coronaviruses are of animal origin. They were first discovered in mammals and birds in the 1930s. The disease that we know as COVID-19 is actually caused by SARS-CoV-2, which is a respiratory virus, and that's the name we give to severe acute respiratory syndrome coronavirus 2. It's really the 7th human coronavirus that was identified. And quite frankly, with some of the other coronaviruses, there was interest, definitely interest, but not as much interest until things like SARS and MERS started to appear, and epidemics that were associated with those diseases occurred. SARS, for example, in South China from about 2002, 2003, there were 29 countries that where this spread to on 3 continents. 8,000 cases and about 774 people died as a result of the spread of that disease. MERS first in 2012, and then again in January of 2020, where there have been over 2,519 cases and 866 deceased. These diseases tended to be have higher mortality than what we saw with and have been seeing with SARS-CoV-2. And maybe because of that, they tended to burn out in human populations. They were able to be controlled until such time as we could get barriers around the spread of the disease. So they weren't as infectious, but they were more deadly in many ways. SARS-CoV-2 just happens to be an agent that is deadly, less deadly than these agents, but spreads more readily. And perhaps these were, again, forewarning that there might be an agent like this coming, but until it happens, it's difficult to fully assess what kind of measures might be needed or might be required to control it fully. When this disease emerged, apologize, I'll go to the correct slide here. And emerging in China back in February 2020, one of the initial concerns that came out, and this is an article that appeared in Transfusion Medicine Reviews in February of last year, one of the concerns that emerged was, okay, what impact might this have in transfusion products, in blood products that are collected from donors who are infected with SARS-CoV-2. I thought this was a very well-written, well-balanced article that was put together by Dr. Chang and colleagues that appeared in this review at the time. In particular, one of the things that they called out was that, we have methods that we can control the spread, and we have experience from SARS-CoV-2 and from MERS in terms of what was done in donor deferrals, donor questionnaires, et cetera. But they indicated here, which I thought was really prudent, that there are differences in these viruses. And so it was difficult, at least they called out the fact that it would be difficult to know whether or not the recommendations that were made for SARS and MERS were going to be sufficient. And I thought very prescient on their part pointed out the fact that in coming months, as stated here, we're going to learn a lot of things. We were going to learn a lot of things about this SARS-CoV-2 and COVID-19, and that really that information as it emerged would allow us to make decisions regarding the virus and public safety. And of course, these concerns existed not only in China, but existed in places around the world as the virus began to spread and become pandemic. Transfusion services, blood banking services around the world began to become more and more concerned about what impact this may have. This came out shortly thereafter in March of 2020. I won't tell you the name of the organization that that put this out. But what I will say is that everything stipulated here is absolutely correct. The likelihood this is a respiratory disease, the likelihood that it's transmitted by blood is extremely low, extremely rare. And I highlighted here one of the things that was said is, blood cells don't have binding sites that the COVID-19 virus is looking for. So the virus is focused on attacking the respiratory and digestive system. So these are statements that are coming out at the time because, of course, with an unknown agent, with people being concerned about the impact that this may have, and again, still being at a place where we have to rely on blood products to provide transfusion support, this is really meant to reassure people that the probability is low that disease is going to be spread by these products for these various reasons. And one main reason being, again, that the receptor and the binding mechanism at this time in March of 2020 were never demonstrated to be present on any of the blood cells. And so the risk of blood cells being infected or being carriers of the virus was called out here as being low to virtually impossible. And the point about that is that the way that the virus infects cells is via binding of the spike protein, or the receptor binding domain, RBD as it's called out here in this diagram, to a protein that's present in the surface of cells, various types of cells. And this is the Ace2 receptor, as you hear. So think about that as sort of the lock and the spike protein being the key. And it's the binding of the spike protein to that receptor, the Ace2 receptor that's present in the surface of certain cells, that allows the virus to enter the cells and then to cause infection once it's inside the cells. And one of the reasons why there are varied responses to the virus that you see in patients is the fact that these receptors are present in a wide variety of different tissue and organ beds, including lung alveolar cells and enterocytes of the small intestine. You may have heard about the impact that SARS-CoV-2 infection was having in some patients with regard to digestive system or GI tract. Even present in cerebral cortex or hypothalamus cells in the brain. And so you heard stories about individuals suffering from what was described as a brain fog. So we learned a lot more about the potential impact, and we saw results in patients that varied considerably depending upon which organ beds or tissues were actually being infected in this process. And it's because of the diverse locations of the Ace2 receptor in these various cells. Now, remember, as was stated previously, one of the main reasons why blood wasn't suspected to be a route or a carrier of the disease is precisely because blood cells don't have these receptors, the Ace2 receptor. That was the knowledge in March of 2020. And interestingly, as people began to look at this increasingly, by June of 2020, this is an article that Steve Spitalnik and colleagues at Columbia University published. This is subsequently published. This was the original medRxiv article that came out, noting that they had, through proteomics, had actually identified angiotensin and ACE2 interacting proteins in the red blood cell surface. So what we had thought didn't exist actually was present. There is ACE receptor there, bringing up the possibility and some of the observations being that red blood cells could actually be infected with the virus, and that infection was actually leading to some changes in the hemoglobin and changes in certain expression of proteins inside red blood cells as part of the normal cell machinery. Now, red blood cells don't contain the apparatus to replicate the virus. So what was being said here is not that the virus was replicating and actively expanding within red blood cells, but rather that the virus was capable of being taken up by red blood cells, internalized by red blood cells, and that would have an impact on the red cells. But the fact that this receptor was present in these cells was something that we learned just in the span of several months of study and investigating the virus, this new emerging virus, and understanding better what some of its properties were. In September of 2020, so a few months afterwards, this article came out, published by colleagues in France, looking at monocytes and macrophages. So another white blood cell population that's present besides red blood cells, and showed through observations that they made in these products that the virus could bind, the virus could be taken up, and the virus again had an impact on the white blood cells that were taken up by the virus in terms of the expression and secretion of certain immunoregulatory cytokines, upregulation of M2 type molecules that could have subsequent effects on how the blood chemistry or blood physiology behaved in patients who were infected with SARS-CoV-2. So again, identifying new populations of cells that carried this Ace2 receptor and hence made blood cells susceptible to infection. Just information that we learned over the course of 6 to 9 months of studying and understanding better the disease's progression. And then this led to a statement. This came out, I believe, in October, November timeframe of last year. This is from the National Institute of Environmental Health Sciences. And I just copied some of the statements that were in this document, which I thought was quite interesting, saying that we know that the virus primarily enters the body through the eyes and nose and mouth and progresses into the lungs. However, by this time, it was pretty clear that the virus replicates in cells, including blood, and that when it does, it can alter the blood's environment. And I think very importantly, what they were saying here, and this is also in this statement, it isn't that it's a blood-borne virus. There's no evidence that it can go from a donor to a recipient, but it can replicate in blood cells, and it could affect the blood and its organelles like red and white blood cells and the hemoglobin and their ability to work effectively. And that may actually have been a reason for some of the observations of the dynamics in patients who were clotting and other effects that were observed in patients who were infected with SARS-CoV-2. So just in the span, again, of, we go from January and the caution that you saw in the article coming out of China about we're going to learn more about this. Maybe what we're doing is going to be enough, maybe not. We go to, it's not there's no way it can infect blood because blood cells don't have the receptors, to first understanding, well, yes, those receptors are present in red cells, to the understanding, yes, those receptors are present in monocytes and macrophage, to yes, we know that those cells can be infected and the virus is likely replicating, at least in some of those nucleated cells. And so it just, I think, goes to show the story about, you don't know what you don't know until you get there. And so taking precautions sometimes are warranted in cases where there's a lack of full information, there's a lack of warning, and a lack of understanding of what the true aspects of some of these diseases may be as they emerge into human populations. Where that becomes really interesting and perhaps even more important is when you're trying to use the blood from patients that you know have been infected to treat other patients, or potentially even to use those products prophylactically to prevent individuals from becoming infected. So knowing what we know about the potential for the virus to be there now and how it can be present in blood cells, if we're going to take blood specifically from individuals in the form of this convalescent plasma, it becomes even more important to understand how that may impact transfusion transmission or increase the likelihood of transfusion transmission. And again, you're doing this at a time when very little is known about the disease and very little may be known about the virus. So convalescent plasma is really a product that's taken from an individual who has been infected and is convalescing or recovering from that infection. And the concept is not a new concept, it's an old concept. It's been around for many years, close to 100 years, in fact, in terms of people utilizing it as a frontline response mechanism to deal with emerging diseases. This pandemic is not the first case where it's ever been used. It was used in the influenza pandemic in 1918. It's been used in pandemics associated with measles, SARS, MERS, and Ebola several years ago. And it's one of the first things that people turn to. And the concept here is that you take a patient who's been infected, they generate antibodies. And if they survive the infection, those antibodies become immunizing, and they can be used in a passive immunotherapy. So you take them from someone who has had the infection and has generated antibodies, and then you take those antibodies and give them to someone else who has just been infected, as a way to kind of reduce the likelihood of the virus replicating and causing widespread infection and broad impact in the individual, until such time as their own immune system can kick in and generate an immune response that keeps the virus replication in check. That's the concept behind it. So if you're taking a product from these individuals and you want to assure that there's a reduced risk of any disease transmission occurring, the question comes in, what can you do? How can you approach this from this standpoint? Well, I think one of the first questions that came out from convalescent plasma, despite this history behind it, was, does it really work? Does it really provide a benefit? And importantly, if it does, what is the best way to use the product? What is the best way to administer it to make sure that we're getting the most effect and most effectiveness out of it? And so there were a lot of clinical trials that were started in the early days. This was a check that I did back in May of last year, that there were over 1,400 COVID-19 related clinical trials. 62 of them were on convalescent plasma. And I think a check that I did even after May of last year showed that that number had increased even more. So there's a lot of interest in trying to understand how to use this, how to make sure that it was the safest product possible when it was being used, and the most effective product possible when it was being used. One of the first seminal papers that came out of this also again came out from China, and again, not surprisingly, it's the first place where the disease appeared, so they tended to be ahead of us in terms of looking at ways to respond to the disease. And this was an article that was published in the Proceedings of the National Academy of Sciences that describes some work, Duan, first author, and colleagues, that describes some work in using convalescent plasma from patients who had recovered to treat patients who were presenting with disease and going through an acute phase of infection. In some of the summary points, they looked at neutralizing antibodies. PRNT antibodies stand for plaque reduction neutralization titer antibodies. So these are antibodies that can bind to the virus and can stop it from infecting a cell. And by virtue of that binding, are able to prevent infection from being spread or from occurring. In this study, all of the patients received plasma from donors of at least a titer greater than 1 in 160. So the higher that number is, 1 in 160, 1 in 320, 1 in 1,020, the higher that number is, it means the higher the antibody levels are that are present. So they used a cutoff value for the products that they administered to patients of 1 in 160. And they saw some promising results from this study. It was an early study, it was a preliminary study, but it encouraged other people to begin looking more broadly at how that might be applied. And again, were these results reproducible, and how reliable was this information? And this is something that came out subsequent to that. It was from a study, a large protocol was put together called the Mayo protocol, or the Mayo Clinic protocol. A large number of investigators across the United States, including here in Colorado. There was the Colorado Convalescent Plasma Consortium that was part of this major program. It was led here locally by Dr. John Eisenach at Kaiser Permanente, who organized groups of blood banking groups, as well as transfusion medicine or hospital clinics, to collect convalescent plasma and to look at outcomes. And ultimately, this data fed into at the FDA with an emergency use authorization. This is some of the data that the FDA looked at. What they found was quite interesting, that, again, if you were at certain titers, and in their case, with titer levels of 1 in 320, they were able to see some significant effects, benefits, relative to the reduction in mortality and hospitalization or intubation rates in patients who were given this product. Importantly, given the product within about 3 days of them actually exhibiting symptoms. So it makes sense when you look at it from the standpoint that if you can get to the patient before they have an extreme of viral replication and infection of the tissues, if you can block it with this passive antibody therapy, then you're much more likely to reduce the severity of disease. And in fact, when they did that and they looked at patients that had these high titers above 1 in 320 in this case, they were able to see as much as a 37% reduction in mortality. So a third of the patients who otherwise would have died who received this therapy within this group, they actually saw a significant reduction in death within 7 days and within 30 days. The results tended to be consistent. Of course, if you don't survive the first 7 days, it's unlikely you're not going to be around for the later time points when the analysis is done. But this actually led to the FDA issuing an emergency use authorization to be able to use these products in patients who were, and again, during the very early days when there weren't other products that were available for people to utilize in treating the disease. We did some work here at CSU to look at products that were collected as part of the program in Colorado as part of the Colorado Convalescent Plasma program in collaboration with colleagues at Vitalant, with folks at Kaiser Permanente and other groups, Children's Hospital here in Colorado, where some of these collections were being done. And our data pretty much lined up very well with the national data that was reported out by investigators in some of the papers and preprints that I referenced here in the last slide. We were seeing titers that on average, we saw an average titer of about 1 in 160 for PRNT50 values in these patients. And you could see that the range, the distribution of those went everywhere from 1 in 10, which is a low titer, up to 1 in 5,120, which is a high-end titer, with the average being somewhere around 1 in 160, 1 in 320, the mean of this distribution being somewhere in that range. So very consistent with what was seen on the national level. We were interested in understanding a little bit more about the behavior of these antibodies, because that is important to inform people about when to collect and whether or not the product that you're going to get is going to have sufficient antibody titers in order to make it worthwhile to collect. So we did some studies on these products looking at not only the PRNT values that you see here, so those overall levels of neutralizing antibody titer, the things that bind to the virus and prevent it from entering the cell, but also specific levels of subsets of antibodies. These are anti-RBD, so these are specific antibodies that bind to that spike protein that you see on the surface of the virus. The idea being that those are very likely to be, and have been reported by others now, to be the most potent agents, antibodies for protecting people against infection. Because if you can bind the antibody to the key no longer fits in the lock, no longer binds to the Ace2 receptor, and so the virus can't enter the cell. Interestingly, what we found is that antibody levels in patients peaked at around 30 to 45 days, the overall neutralizing titers. These are days post-infection, days from infection. You could see in these various groups. By about day 15, everybody is positive, who is infected, is you see antibodies present, and the neutralizing antibodies present. So that's where the peak occurs, about 30 to 45 days. Everybody starts showing them around 15 days post-infection, both the anti-RBD antibodies and the PRNT, the overall population of neutralizing antibodies. More interestingly is some of the data that we saw when you look at, break it down into overall neutralizing antibody, and you look specifically at these anti-RBD antibody sets, where we see total neutralizing antibody peaks around 30 to 45 days. The level of anti-RBD, the stuff that binds to that spike protein and and inhibits its entry into the cells via the receptor, those levels tended to remain consistent and high at least up to 90 days after the individual was infected from the samples that we looked at here. And I will say that from data that's subsequently published by Rabiani et al. And others that worked in the larger Mayo Clinic study, this data was very consistent and very reliable, rather, to predicting whether or not there were sufficient antibodies there for the product to have some beneficial therapeutic effect in individuals who were transfused with those products. Another thing which was pointed out in this article by Duan et al., again, this seminal paper that came out very early in the process, was that in order to address the question about is there any live virus that we might be collecting, we certainly don't want to be transfusing live virus. And again, this is at a time when we knew very little about how the virus behaved, whether it was in blood, how long it persisted, whether it was infectious. What they did to counter that is they applied pathogen reduction technology. And this was something that they did to all of the products that they transfused. The particular form of pathogen reduction technology that they use is a process called methylene blue that relies on a chemical methylene blue and light, visible light, in order to achieve an activation of the virus. There are several methods that have been developed over the years. Some of them are described in this review article that my colleagues and I wrote back in 2014. There's the Theraflex methylene blue method that I mentioned, which is used for plasma. There's the Intercept method, which is used for platelets and plasma. That's a product that's approved in the US for treating plasma and platelet products. There's the Mirasol product, which relies on riboflavin and UV light, used for platelets, plasma, and red blood and whole blood. Outside the US, it's used in countries where the CE mark is recognized for marketing authorization. And then the Theraflex UVC method, which is being used for, or proposed to be used for, platelets. I don't know if that has received approvals yet. But these are all methods that have been used. They all have their pluses and minuses. There's a lot of literature that's out there, and you can review that literature on your own. But these are methods that have been developed to treat blood products to prevent transfusion-transmitted disease, just this kind of incident that we're talking about, to add that extra layer of protection in cases where we know the transmission can occur, and even in cases where we don't know, but we're learning as we go, such as we had with the SARS-CoV-2 entry into human populations. I'm always asked this question about how much is enough? How much do you have to kill to be effective? And that question varies, and it varies from organism to organism, and whether you're talking about viruses or bacteria or parasites that are present in these products, whether it's intracellular or extracellular. It's hard to give a single answer to this question. What I wrote this article in collaboration with some of my colleagues a few years ago, describing some of the dynamics of viral infection in a transfusion setting and how we might look at this in terms of answering that question, what's effective? And importantly, and I think as was pointed out in one of those earlier papers, a person who is really viremic, when someone comes in and it's a period of time after they're infected, that the virus has had a chance of replicating, it's very unlikely that they're going to be qualified as a blood donor. They're probably feverish, they may have lethargy, they may have other symptoms, and they're likely to be removed from donation at that point, which is why peak viremia, although it represents the greatest threat to transmission, because there's more virus there, actually in some ways from a transfusion standpoint represents a lower threat if those individuals are symptomatic during that period of time. It really is during this initial period, when called the window period, when viral titers are low, and they're low enough that you're not seeing symptoms, or they're low enough that if you have a test, you can escape the sensitivity of the test, and a product which is really positive would be reported as a negative because you simply weren't able to detect the few infectious particles that were present. That's the danger zone. And that's actually where PRT methods may be the most effective at being able to prevent transmission, because this would be a donor who may donate, who may not show signs, who may not show a positive in a test, but have enough virus there in order to transmit to another individual and cause infection in that other individual. The cutoff for testing is usually somewhere in the range of about 2 logs. So when a test exists, that's usually if you have about 2 logs per ml of material in a product, or copies per ml, if you're talking about nucleic acid amplification, you can usually find that needle in the haystack at those levels. When you get below those levels and you could still have infectious material, but you can't detect it, that's where a danger zone exists. My colleagues and I at Colorado State University, very early on, we are funded through the U.S. Department of Defense through grants to look at the efficacy of pathogen inactivation methods with blood products to prevent transfusion-transmitted disease. So very early on, we turned our attention to utilizing one of the methods, which utilizes riboflavin and UV light, to inactivate SARS-CoV-2 in blood products. And our study involved plasma and whole blood. And I believe there was a subsequent publication in platelets that also demonstrated effectiveness there. But the goal of these studies was really to see if the virus is there, do these methods kill it? And do they kill it at a sufficient enough level that gives us some degree of comfort that if there is contamination present, we're going to reduce that by a significant amount. And our early studies, and this is published data that you could go to in PLOS One, showed that we were able in plasma products, despite differences in volume, even at partial energy doses to the full dose of light being delivered, we were able to see inactivation of the SARS-CoV-2 virus in plasma products greater than or equal to 3, greater than or equal to 4 logs of virus. So that's 99.9 to 99.99 x% reduction in the level of infectious virus particles by treating these products with this process. And with whole blood, similarly, saw about 3 logs of reduction. In this case, we didn't get to the limits of detection in those products, but we were able to show consistently greater than 3 log reduction of live virus that was spiked into whole blood products treated by this process that involves riboflavin and UV light to inactivate viruses in blood products. And again, that data was published. Being able to kill the viruses in blood is not the challenge of and by itself. Being able to kill them and preserve the therapeutic efficacy of the blood components is the challenge. I always tell people that killing stuff in blood is easy. You just add bleach. But if you did that, you probably wouldn't have anything that would be efficacious and probably ill-advised to transfuse it into a person after you were done. So killing the pathogen, but keeping the therapeutic components, the plasma proteins in this case, if we're dealing with convalescent plasma, that's the thing that has to be achieved. Both of these have to be achieved in a balance in order for you to have an effective therapy. This is a preprint, data from a preprint that colleagues and I published in medRxiv recently, and it has just been accepted for full publication in Vox Sanguinis, which is the journal of the International Society for Blood Transfusion. And these were some samples of convalescent plasma that we took from individuals who had survived COVID-19 and had donated plasma after their recovery during the period where they're convalescing. These were from 3 females and 3 males, donors in the age range from about 27 to 45. And we looked at the impact of the process on plasma protein components. With these processes, you're handling products, you're manipulating them, you're treating them in ways they're not usually treated. Very well documented, tons of literature with the different methodologies. Depending upon the proteins, the more labile proteins in blood, you'll see anywhere from about a 10 to a 30% loss in coagulation factor activity by doing these treatments. In this case, with these products, we also looked at what's important, what the therapeutic component is for convalescent plasmas, not the factor VIII or the fibrinogen, it's the IgG, the IgM, and the IgA. And with these materials in a very generic way, there's extremely high retention, 90 to 100% retention of the activity of that component, which is the therapeutic component of convalescent plasma. If you look at neutralizing antibody titers before and after treatment, no change in the overall neutralizing antibody titers that you see. These aren't the highest titer materials because, again, the high titer materials, we're giving those to patients. So these are some materials that were at relatively lower titers, one exception, the 1 in 320 that you see here. What we really were interested in is what does it look like before and what does it look like after, and is there any change? Are we destroying any of the neutralizing capacity that's present in these products? And importantly, we were also able to look at those specific subsets, those more potent antibodies that I was referring to, the receptor binding domain, the S1, which is the spike protein, a portion of the spike protein, the S2, which is another portion of the spike protein, those things that bind to that key and block it from entering the lock. And before and after treatment, no significant differences in either IgG or IgM levels for these particular antibody subsets present in these products. And again, this data has been published now, or will be published in Vox Sanguinis. I had an opportunity to take part in a seminar recently with a colleague, Dr. Pavel Trachman, who is the head of the Department of Transfusion Medicine and the Stem Cell Bank at the Russian Federal Center for Pediatric Hematology, Oncology, and Immunology. We've interacted for many years in this space. As you can imagine, blood safety for patients who are pediatric oncology patients is of paramount importance to people to make sure we're giving them the safest product. These are oftentimes patients who are severely immunocompromised because of the chemotherapy regimens that they're receiving or the treatments they're receiving in stem cell transplant protocols or other protocols. Pavel was one of the first people to adopt the convalescent plasma treatment for patients, again, very early when we didn't have a lot of knowledge about the material, but we're trying things to try to improve outcomes in patients when no therapeutics were available. And when we had, we had patients, individuals had patients that they were treating physicians who had very few resorts available to them for treatment. And he provided me with this data, kindly provided me with this data. They were collecting about 600 mils of apheresis plasma, treating it with the Mirasol PRT system. This is a group that has been doing treatment with this riboflavin and UV light technology now for, I think, close to 10 years for products in routine use. And then they did, of course, their routine testing, their routine QC on these products. And this was starting back in April of 2020 when they first started doing these collections. They treated 11 patients. This is some of the data that he shared with me and in his presentation. Usually about anywhere from 1 up to 4 units of FFP that were collected from convalescing patients. And what you see is the persistence of the signal in these patients, indicating a PCR positive that replicating virus is present. One of the reasons why it persists for as long as it does is because these individuals don't have B cells to produce antibody, and hence they're immune compromised because of the treatment they're receiving for their underlying disease. And so providing them with a passive antibody therapy was an approach that Pavel and his colleagues were trying in order to help alleviate disease in those individuals. These are 2 of those 11, a little bit more detail, with a 9-month-old girl with juvenile chronic myelogenous leukemia who was given a haplo stem cell transplant in January of 2020. Day 125 showed positive PCR for COVID-19 without symptoms. By day 144, actually started to show dry cough, shortness of breath, decrease in saturated oxygen content, and lesions on CAT scans, essentially, that were done on her lungs. Given antibody and given therapy to address the buildup of the damage that was being seen. And then also importantly, given the COVID-19 recovered FFP 3 doses at days 1, 2, and 10 post-symptoms. So again, early in the onset of disease in this case. Went on, again, this is an individual, this child had no CD3 positives, no immune system reconstitution, low levels of CD3 positive cells, complete absence of B cells because of the treatment that they were receiving, the stem cell transplant, the chemotherapy regimen. The clinical symptoms fortunately resolved after 3 weeks of treatment. There were still detectable antibodies that were present. Now, these had to come from the passive administration of the plasma because there weren't cells on board to be able to produce those naturally. So there were still antibodies detected 5 days after the last FFP. And this was an individual in which the PCR positivity or the presence of live virus was detectable for up to 4 months after it was originally found. And again, reflects the immunocompromised status of the patient. This is a second patient, a 17-year-old boy with acute myelogenous leukemia. 10 months after a stem cell transplant, had a relapse, came up positive for PCR at day 314 post their transplant. Day 317, it was so bad they had to be intubated with oxygen. The individual was given 3 units of recovered plasma at days 3, 4, and 6 post the symptoms. This is what the lungs on the left of this individual look like. And everywhere you see sort of the whitish areas, that represents occlusion in the lungs. I'm sorry for the light coming in on my face here. I'm gradually trying to move with the sun. This shows you the severity of the blockages that occur in these individuals when they're infected with COVID-19. And on the right, 11 days post-onset, so this is after the convalescent therapy has been administered, you begin to see the clearing that's occurring in the lung and the reduction of the number of lesions that are observed here. So major improvement 2 weeks after treatment, incomplete recovery after 2 weeks on conventional therapy. And there were detectable antibodies 5 days after the last